Thanks for taking time today to discuss a need that's of urgent importance to cardiac and pulmonary rehab programs in this country. I've been a cardiac rehab nurse for 30 years, and I speak as a past president of the American Association of Cardiovascular and Pulmonary Rehabilitation at ACVPR, along with our state affiliate members that deliver these services in hospital outpatient departments. I'd like to begin by taking a brief 3 minutes to give you a visual tour of a typical cardiopulmonary rehab program. This one is at Mayo in Rochester, showing a program in action, offering a patient's perspective, and providing some evidence for these two treatments.
With his heart pumping more efficiently, Ron felt his energy rebound within a matter of days, but his road to recovery was just beginning.
3 weeks after surgery, I began the formalized program of the cardiac rehab.
Every medical or health measure you can imagine gets better with cardiac rehabilitation. So people function better, their physical strength, their endurance, their ability to do things improves, balance can improve.
Also very important is to keep patients out of the hospital, so patients who are participating in cardiac rehabilitation are less likely to be rehospitalized.
Ray Squires is program director for cardiovascular health and rehabilitation at Mayo Clinic. He says, contrary to what many people think, it involves much more than just supervised exercise.
It's attention to modifying risk factors such as high cholesterol, high blood sugar, uncontrolled blood pressure, obesity, depression, obstructive sleep apnea, etc.
Ron's 3 months of outpatient therapy, 3 days a week, is typical. It starts slowly and increases in intensity, always under a watchful eye.
There's a very close monitoring. They have leads on and they watch to see what your heart rate is. They monitor your blood pressure.
We're looking at his heart rhythm, so we're making sure that all of his beats look the same.
Ann Walter is Ron's cardiac rehab case manager. She says he made her job much easier in one regard.
He had been an exerciser his whole adult life, and so we didn't have to talk him into the benefits of exercise. Some of our patients have never exercised at all.
So nationally, only around 20 to 25% of eligible patients receive cardiac rehabilitation services.
Dr. Randall Thomas says that's very unfortunate because Mayo Clinic's research shows those who do experience greatly improved survival rates.
We've looked at people after angioplasty and stent placement, after heart surgery, after heart attack, and in all those studies consistently we find there'll be a 45% difference in death rates in those two groups over the subsequent 10 years.
I mean, the bottom line is they live longer. There's a mortality benefit to participating in cardiac rehabilitation.
Dr. Squire says part of the benefit is that the program educates patients, instilling a greater overall commitment to staying healthy.
Patients who participate in cardiac rehabilitation are much more likely to comply with their medications long term. They're much more likely to comply with dietary measures, exercise, all those kinds of things.
I feel fantastic. I can tell that I can start to run faster, and I can just tell my heart, my lungs are working much, much better. But that took several months to reach this point.
For the Mayo Clinic News Network, I'm Dennis Doda.
So cardiac and pulmonary rehab are well established as low-cost, high-value services. And what does this mean in today's healthcare system that is moving slowly toward value-based care? Value refers to meaningful outcomes, like we just heard, like decreased hospitalization, less use of emergency room, fewer physician office visits, and the decreased mortality rates referred to above, an improved quality of life. The whole care coordination and medication reconciliation aspect, simply put, these outpatient treatments are the standard of care for secondary prevention. In fact, CMS Innovation Center, NHLBI, NIH, and the Million Hearts Project have focused on underutilization and set goals to improve participation. With Million Hearts, the goal is to get cardiac rehab utilization up to 70% of those who are eligible. And as you heard on the video, it's under 30% right now. So we're looking at the barriers. One barrier is a waiting list of 30 to 60 days average post-hospital discharge. Now keep in mind, CMS's stated expectation is 2 to 3 weeks max delay from hospital discharge into cardiac rehab enrollment. Delay is primarily due to capacity limitations of programs. We know that earlier enrollment reduces that non-participation. In fact, every 1 day of delay is a 2% decrease in someone likely to sign up or start the rehab program. And we know from studies, more sessions equal better clinical outcomes. So there's a dose-dependent efficacy to these services. A bit of history. In the 2000s, physician offices progressively stopped delivering cardiac and pulmonary rehab. They just didn't have the economy of scale needed for the level of reimbursement that was received in those offices to provide these programs. Think about what you just saw, the staff, the space, the equipment. As you saw in the video, it's not just a session of PT with your physical therapist. It's quite different than that. So today, the vast majority of cardiac and pulmonary rehab programs are in a hospital outpatient setting. Meanwhile, the trend in healthcare in the past decade by hospital was to purchase some of the physician's services, practices. What this did was raise Medicare costs, with physicians and hospitals billing Medicare for some outpatient services with higher reimbursement rates, sometimes as much as 140% higher. For example, CT scans brought in under the hospital outpatient umbrella, MRIs, stress tests, long list. So the Balanced Budget Act of 2015 included Section 603, directly intended to discourage that practice. They could see the amount of dollars spent more on the same service delivered. So in Section 603, just to review, any hospital off-campus services that were established or moved to a different location after November of 2015, that bill date pass, would be reimbursed at a physician fee schedule equivalent, meaning a 40% decrease in reimbursement from the hospital outpatient reimbursement levels. So to put it in perspective, Medicare reimburses cardiac rehab $116 average for an hour session. Pulmonary rehab is reimbursed $45 for an hour session. That reduction of 40% for both services means it's just not financially sustainable in an off-campus location that wasn't grandfathered by November of 2015. So the result is Section 603 itself is a huge barrier to expanding cardiac and pulmonary rehab services to meet these capacity limitations, exactly in contrary to what other offices at CMS are working with us so hard to try and improve. In 2017, we explained this dilemma to CMS, the Coverage and Analysis Group, who said, yeah, that was an unintended consequence. You're going to need to have it corrected through legislation. We can't do anything statutorily. So here we are. Now, others on this call have some examples to share of their own current situations. For example, an on-campus rehab program has 800 square feet. They can't afford to move to the large medical fitness center that the hospital owns just off campus that has 5,000 square feet available for this exercise service. An off-campus cardiac rehab or pulmonary rehab that was established before November 15 has outgrown that space and has the opportunity to move to a larger space, but financially can't do that because of Section 603. Or administration needs hospital space and moves that rehab program to an off-campus location, either realizing or sometimes not realizing the negative financial consequences until it's too late. And those situations are presenting themselves all the time, all over the country, in each state. So this is the 4th year we've come to Congress seeking a correction to these unintended consequences of Section 603 for the rehab programs. Each year there's been a better understanding of the predicament we're in. If I may briefly share some letters that were sent to CMS administrator from both the US House and the US Senate in the fall of 2018 that echo what we are observing. The Senate letter was signed by 48 members. And to just pull out a few quotes, The facilities impacted by this rule include those that provide care to some of the most vulnerable patient populations in difficult to serve areas, and a number of changes in the rule are needed to ensure that they can continue serving these communities. This unfairly penalizes grandfathered off-campus provider-based departments that expand the critical services they offer to meet the changing needs of their patients. The House bill, similarly, which was signed by 138 members, said it's unclear how CMS has deemed all of the outpatient department services at these grandfathered campuses as cause of an unnecessary increase in volume of outpatient services. Cutting payment to 40% of the current outpatient department rate to furnish a new service from a clinical facility not offered prior to November of 2015 could unfairly penalize grandfathered off-campus departments that expand or diversify the critical services they offer to meet the changing needs of their patients. These changes should not diminish progress made in the shift to value over volume in today's healthcare system, potentially diminishing provider desire to invest in these positive changes. I think Congress articulately expressed exactly the same issue that we are trying to convey. I'd like to show you a slide that, in a quick catch, kind of reflects Medicare data for cardiac and pulmonary rehab services under physician fee schedule. This is a 5-year look at from 2012 to 2016. And what this data shows is that physicians are not billing cardiac and pulmonary rehab. They're not in that business. And the number is decreasing here as you go across the years over this 5-year span demonstrate that. You can see expenditures by Medicare to the top specialties that would be the primary users of cardiac and pulmonary rehab, cardiology and pulmonology, are very low. The solution then is a bipartisan bill, both in the House and in the Senate. In the House, Mr. McGovern from Massachusetts and Mr. Adrian Smith from Nebraska introduced last Congress HR 4838. We had 24 sponsors at the end of the 116th Congress. Likewise, in the Senate, Senator Hoeven and Senator Doug Jones introduced Senate Bill 4151 in the 116th. We are now seeking a Democrat to reintroduce, along with Senator Hoeven, on the Senate bill. What this bill proposes is a financial exemption for any hospital outpatient service where the physician fee schedule utilization is less than $2 million per year per specialty. Now, this threshold indicates a service that is not a significant physician service and therefore not contributing to the problem that Section 603 was created to address. That service would remain then under outpatient prospective payment system, regardless of the off-campus location where the service is provided, grandfathered or not grandfathered. We initially turned to the American Hospital Association to assist us in finding other outpatient services in the same dilemma. We could find none. But this is not a carve out just for cardiac and pulmonary rehab services. You know, it may be that such low reimbursement rates are unique to cardiac and pulmonary rehab. We don't know. In April of 2020, AACVPR had an external CBO score analysis done, and the conclusion was an estimated cost for this bill at $7 million per year. This was very encouraging to see that the cost should not be a barrier to passage of this bill. Our partner professional cardiac and pulmonary rehab organizations are all in support and agreement on the need for this Medicare fix. That includes American College of Cardiology, American Heart Association, American Thoracic Society, American Association of Respiratory Care, and a number of others. Happy to answer any questions you have, and if I don't have an answer, I know I can find someone who does. The second issue we just want to briefly review is simply to make you aware of the increasing use of virtual delivery of cardiac and pulmonary rehab that we're addressing with CMS. The PHE forced many programs to close. Most have begun to reopen gradually and safely. During the PHE, through a CMS relaxed regulation, the direct supervision requirement was extended so that cardiac and pulmonary rehab are able to provide that direct supervision through a virtual presence of that supervising physician using real-time audiovisual rather than a physical presence. This eased the barrier of not having a physician physically there or physically tending to emergencies or other places on the campus. A CMS waiver is allowing the delivery of virtual cardiac and pulmonary rehab sessions in the patient's home during the PHE. And this is also via real-time audio video technology between clinical staff and that Medicare beneficiary. AACVPR and partner professional organizations are asking CMS to make both these temporary changes permanent. A hybrid model of combining center-based sessions with non-center-based addresses numerous barriers to participation, such as rural deserts where there is no cardiac or pulmonary rehab program available, transportation challenges, underuse by certain populations, such as minorities, inner city, women, older adults. In fact, early research suggests better participation rates for virtual sessions over center-based. As we look for solutions for the underutilization of these services, we may ask for your support in the future as we try to work with CMS on these requests. Thanks for your time.